Okay, I'll try to record the session so that other people have an opportunity to see it if you happen to drop out. Well, welcome everyone to Paediatric Teaching today. There's a lot of people still coming online, so I'll let them in as we go. I'll just share my slides and we'll make a start. Okay, well, I hope you can see the slides I've got up. If anyone can't see them, please let me know. Today, well, hello everyone and welcome. I see we've got a lot of people online today. So Annette Garai from Vanuatu, welcome, and Rachel Master, welcome. Wilma Luan and Geraldine Legani, and there's a lot of Galaxies and Nokia people. I'm not quite sure who they are. Kaspari Amont from Goroka, welcome. Look, today, and there'll be other people sort of come in as we keep going, but today I wanted to, usually in these sessions, I try not to talk about COVID. I try to talk about other, things of importance to paediatric training, to what you need to know as paediatric registrars. And I think there's enough said about COVID that perhaps we don't need to say too much more. But I thought today, because there is some new information available, and there have been changes that have happened in COVID, I think in 2021, that I thought it was worth just going over an update about COVID and the way it's affecting countries throughout the world. And I particularly wanted to say something about the Delta variant, because that's the type of COVID that we've got in 2021 that, at least in most countries, that seems to be the one that's, I'll just let a few people in, that is the one that is causing the most trouble, I think, at the moment. I wanted, in regard the COVID in 2021, I want to talk about vaccines and vaccine effectiveness, because some people might be under the impression that the vaccines are less effective in 2021 because of the new variants. And I think that's not really true. So, could you please mute your microphone, thanks. So I'm going to be talking about, it's really a COVID update. COVID in 2021, particularly the Delta variant that many of you will have heard of, something about vaccines and vaccine effectiveness in the time of the Delta variant and other variants. And I'm going to be talking a little bit about the multi-system inflammatory disorder in children, because that's being described in many countries. And I just think it's useful for us to have a working understanding of the multi-system inflammatory disorder that occurs in children, and just a good clinical understanding of it. Okay, so that's the talk today. As I say, we don't usually talk much about COVID at these sessions, but I thought today, more than halfway through the year, it was about time we did again. Right, so this is what I'm going to talk about. Many of you will have heard about these things, I think, in other medical presentations, in social media, even in the newspapers. I'll talk a bit about these things called variants of concern. WHO is calling these a number of different types of COVID variants of concerns, and I'll particularly talk about the Delta variant. I'll say something about its severity relative to the original COVID virus, something about the transmissibility of the Delta variant particularly, and I'll say something about the vaccine effectiveness. There's lots of other people coming online now, so I might just wait 10 seconds until they're in. Okay. All right, so as I say, we'll talk about the variants of concern. We'll talk about this condition called multi-system inflammatory syndrome in children, or some people call it MISC. And it's not very common, actually. It's not very common, but it's being described in countries throughout the world. And I think it's just important for us to have a good understanding of what it looks like and how you treat it. Okay, and I'll say something about COVID and children in the Pacific because there is some new information about that in some countries. Right, so that's the talk. Right. So the World Health Organization in the last couple of months has described these types of COVID virus, the SARS-CoV-2 virus, that they've described them as variants, some as variants of concern. And all of you know, I'm sure, the structure of the coronavirus now. It's got those spike proteins on the outside capsule of the virus, and all the variants affect the spike proteins. And that means that the spike proteins are the proteins, as you know, that are involved in the way in which the virus gets into cells. Remember, through those angiotensin converting enzyme receptors on the respiratory epithelium. That's how the virus actually enters cells, and all the variants affect the spike protein in some way. Now, what's important to know about these variants is that it's a relatively normal thing for viruses, because viruses mutate in the process of normal replication regularly. And so it's not something that's bizarre or something that's strange. It's something that just happens naturally, that mutations arise from viral replication in the normal phase of viral replication. And it happens to almost all viruses. I mean, some viruses are more stable than others, and some viruses are mutating more regularly. And COVID just happens to be a, sorry, I'll just let some people in. COVID just happens to be a virus that seems to mutate a bit more regularly, as does the influenza virus. It mutates regularly, and there are variations of it every year. Every year we have a different variation of the influenza virus, and that means that we are a bit more susceptible than what we were last year, because the immunity we've got is good enough for last year, but it may not be good enough for the virus that we are faced with this year, for example. Typically, these mutations or these genetic variants arise in very heavily infected populations, and it's not surprising that most of the variants have arisen in countries where there's big populations and they're very heavily infected, in people who have been chronically exposed to and infected with COVID-19, such as in Brazil, in South Africa, in the United Kingdom, and in India, of course, where the Delta variant arose, in heavily infected populations where the virus is replicating a lot. Then there's opportunity for mutation to occur. Now, as with all viruses, when they mutate, the variant only survives if there's some. Oops, sorry. Okay. The variant only survives if it has some sort of competitive advantage over the other variants. And so if it can replicate faster or easier, or it's more transmissible than the older variant, or it can escape immunity in some way, our own natural immunity or vaccine immunity, then it's more likely to survive. It's like a sort of Darwinian survival of the fittest virus. Yeah? That's easy to understand. Some variants don't survive because they're inferior, as in they're less transmissible, or they're less virulent, and so some variants appear and then they die out, and that's the case for some of the COVID variants as well. And occasionally, by chance, there's an old concept called the founder effect. And if you look this up, you'll see that it's been well described for hundreds of years. And if the first virus in a given community is a relatively innocuous or inferior or benign virus, and then it's likely to, then that may survive within a given community. And that's called the founder effect. The first virus there has a strong competitive advantage over other ones. And so sometimes by chance, you'll get a mutation to an inferior virus, not inferior, a less aggressive virus. And therefore that may mean that instead of the virus just getting worse and worse and more virulent, it may actually become less pathogenic. But I don't think that's going to occur with COVID. I think there's been mostly the genetic variants that seem to be surviving seem to be as pathogenic or a bit more. This is not a new thing. It hasn't only just happened in the last few months. In fact, the first spike protein genetic variant was identified in March 2020. I talked about this even last year, that the first one was identified in March 2020. So that's just after COVID first appeared in Wuhan in China, and maybe as early as January. So these genetic variants have been around for a long time. The one that was most described before Delta was this one called Alpha. I mean, they go by the Greek alphabet: Alpha, Beta, Gamma, Delta, Epsilon, Kappa, Lambda variant now. The Alpha variant arose in the UK. Remember I said that variants seem to arise in fairly heavily, densely infected communities like in the United Kingdom. And it was the first one that was well described. There are others that arose, but this is the first one where there was good science behind it. And it showed that this variant was more transmissible and was probably a bit more virulent. In fact, it was said to be 36% more likely to cause death. This is back in January of this year. And this was quite a big concern because the United Kingdom had gone through a stage of the first wave and seemed to have got over it. And then the Alpha variant arose. And so this raised the possibility that other variants might arise as well. Now, WHO now say that these are called the variants of concern. You don't need to know all about them. I don't think it's easy to remember. They're named based on the Greek alphabet. They used to be named based on numbers and no one could remember them. So they've changed that now to be the Greek alphabet: Alpha, Beta, Gamma, Delta, and now Kappa. And there's one called Lambda as well. It's arisen in South America. But the Alpha variant was from the UK. The Beta variant was from South Africa. This was quite an important variant because when the first vaccine trials were being done, this had a big bearing on whether or not the vaccine was very effective in South Africa or was a bit less effective. And it was shown that the vaccine was a bit less effective, still effective, but a bit less effective in South Africa because of the Beta variant being the predominant one there. Then the Gamma variant, which you probably heard about in Brazil, was important. And then now the Delta variant, which I'm going to talk about predominantly today. There's one called the Kappa variant, which seems to be a bit more benign, and so it's developed only since December last year, and that seems to have, even though it can be transmitted more commonly, it seems to have reduced virulence. It functions a bit more like a common cold virus. So maybe there's hope that some of these variants will reverse to something that's a bit more benign. The Delta variant there probably is an increased transmissibility, and there probably is an increased risk of mortality. Maybe not threefold. That's what WHO had initially said, but I think perhaps it's not that high. It has a high transmission rate and a high reinfection rate. So if you've had it once, you can still get it again, it seems. A bit more likely, a bit more commonly than what the original COVID was. The key thing for us is that it does affect younger age groups, and this is the major difference, I think, with the Delta variant. So I'll just talk a bit about that. It arose in India again last year, and it seems that there's increased transmissibility, like 40 to 60% more. It's more transmissible. And from studies that have been done in Scotland and Canada, there appears to be increased severity of disease. So it arose in India, and now it's present in 98 countries throughout the world. And it's actually in many countries, it's the dominant variant. So in India and the UK and Israel, Philippines, Indonesia, Thailand, it's the dominant variant. And certainly in Australia at the moment, it's the dominant variant that we're dealing with. The one thing about it is that it seems to be associated with very high viral load, which means like the amount of virus in a person's body or in their throat, in their nasopharynx, seems to be much higher than with the previous variants. So that's probably why it can be transmitted a lot more readily, because whether you transmit a virus or anything, like whether it's TB or what, depends on viral or the bacterial load that an individual has. Same for HIV or TB. The transmissibility depends on the bacterial or the viral load. As I say, the one thing with the Delta variant is that children are much more likely to be infected, and so we've all across the world, really, there've been a lot more outbreaks this year among children or in schools, and certainly in Australia we've had many teachers affected. Probably the classroom's been affected, and so teachers have become affected. The symptoms are similar to the other to the original COVID, maybe a little bit different, and that things like loss of smell, the loss of sensation of smell, it does occur with the Delta variant, but it's less common. And so it does seem that the Delta variant produces more just common cold and flu-like symptoms. And of course, in some people, it produces severe disease. Abdominal symptoms that used to be were quite common with the original one seem a bit less common, and as I say, more likely a cold. I've seen children with bronchiolitis, or children with croup, children with a pneumonia, or just flu-like symptoms. And a bit like the loss of sense of smell, there are some people with Delta variant that seem to lose their hearing, and that wasn't described with the previous variants. This just shows. This is a graph that just shows the rise in the Delta variant among children in the United States. Now, I only show this because you all know how well vaccinated the United States population is. They're doing quite well in terms of vaccinations, but still their Delta variant prevalence among the pediatric populations is still quite higher than what it was 12 months ago. It's still not very high, not like it is in adults, but it's quite higher than what it was 12 months ago. And it used to be that the cases of COVID were only like a few percent in children, but now perhaps they're more like 15% of all COVID cases are children. And certainly in Australia at the moment, it's somewhere between 15 and 30% of all new infections are children. Now, much less common that children are hospitalised, and I'll talk a bit about that shortly. I've mentioned those. Right. In children, the Delta variant, of course, produces mostly mild upper respiratory tract infections, and only about 1 to 3% of all the COVID-affected children need to be hospitalised. Remember that that's rather similar to the way it was last year as well. About 1 to 3% of all infected children. It's just that there are more children infected because children seem to be a bit more affected by the Delta variant. Often though, the reason why a child is hospitalized is not because of the COVID virus, but because of some other illness. Like they might have diabetes, or they might have an infection. We had a child who passed away in Sydney just over the weekend with pneumococcal meningitis, and that child also had COVID. And similarly, is what's being found in Fiji is that children are coming into hospital with some other disease, but they also happen to have COVID as well. Now, I wanted to touch on the effectiveness of the vaccines against the new variants. This is very important because it might be that people think that the vaccines are not very effective against the new variants, but that is wrong. And there is a bit less effectiveness of the vaccines, but I've just put it here. This is a graph from a paper that was just published this week, and I think it's very important information. And that is if you've only had one dose of the Oxford vaccine, that's the vaccine that most of us have had, sometimes called the AstraZeneca vaccine, the Oxford vaccine. If you've only had one dose, then the effectiveness is probably only about 30%, which is not very effective. But if you've had two doses, then the effectiveness is 67%. That's quite effective. Now, that's just that's effectiveness that protects us from actually getting the virus, right? And although it's nice to be protected against getting the virus, even if we got the virus and you only have a mild illness like a cold, then that still means the vaccine's working. And the effectiveness, I'll just let a couple of people in. So just to summarize that study that was recently published just last week, the AstraZeneca or the Oxford vaccine, if you've had 2 doses of that, then you're 67% effectively protected against the Delta variant. That's very important. So it's a good vaccine against the Delta variant. That's rather similar to many other vaccines we have, like for example, the influenza vaccine that is given to many in many countries each year. The influenza vaccine is no more effective than 67%. There are some vaccines, of course, that are more effective, like the measles vaccine. That's much more effective than 67%, but still, it's quite an effective vaccine. But the important thing is not so much its effectiveness against actually getting the virus, but the effectiveness against getting very sick. And for people who've had 2 doses of the AstraZeneca, the Oxford vaccine, that it is extremely unlikely that those people would get very, very unwell or die. In fact, I think I only know of one person who was 90 who'd had 2 doses of the Oxford AstraZeneca vaccine and then died from a breakthrough infection. And so it's almost 100% protected against dying from COVID. And I think that should be very reassuring for us, that even though it's not fully protected from getting the virus, it'll protect us very strongly from getting very ill with the virus or needing to be in intensive care or dying. In some countries, this is sort of important too. In some countries, what is being found is that the immunity may wane over time. Like over the first year or so, our immunity after the vaccine may reduce over time. But this is not new either. So, for example, with the pertussis vaccine, if we haven't had a pertussis vaccine in 10 years or even a few years, then our immunity is very low. It's different to say the measles vaccine, 2 or 3 doses of the measles vaccine, and we are more or less protected for life. Because it's a very strong vaccine. But for some of our vaccines that we already use, like pertussis vaccine, the immunity wanes over time. Well, just a bit more people. But even in countries that are finding that the immunity reduces over time, the most severe disease is still occurring in those people who are unvaccinated. So even if your immunity wanes over time, you're still unlikely to get very sick from COVID. I won't talk too much about the Sinopharm vaccine, but this is it's the Chinese vaccine, which some of you will have heard about. It's a slightly different sort of vaccine to the AstraZeneca vaccine, and it's been said, a lot of people have said that it is also not very effective against the Delta virus, but it's not as effective as the AstraZeneca vaccine. But if you get 2 doses, it still provides pretty good protection against the Delta virus. And in some countries of Asia where the Sinopharm vaccine has been introduced, then they're starting to give an extra booster dose and finding it being reasonably well protective. There's lots of other reasons why. So just in terms of the vaccines, I wanted to just say that no vaccine, none of them are 100% effective, but they're close to 100% protective against mortality, and that's what's important. Sometimes people will get a breakthrough infection of COVID even the week or 2 weeks after they've been vaccinated. Well, that's not a vaccine failure. That's just that the vaccine hadn't had enough time to work. And really important that we need to get out is that if you've been vaccinated and you happen to get a COVID infection, then it's much milder than in people who are unvaccinated. And that's why I say a mild case of COVID is not a vaccine failure. It's just the vaccine is protecting us from dying. And the same is true for measles vaccine. If you've only had one dose of measles vaccine, you can get a mild case of measles, but you won't die. A child won't die from measles if they've had one or two doses. They may get the rash or they might get a fever, but they won't die from measles, and that's what's most important. Okay. There are some countries where these breakthrough infections are being described quite commonly. There are particularly countries in Asia, and they're countries that are using the Sinopharm vaccine, but it's a bit lower effectiveness than the Oxford vaccine, the AstraZeneca vaccine, but it's still a useful vaccine. And if that was all that was available, that's the one. Okay, so that's all I wanted to talk about, the Delta variant, because I wanted to talk about that because I think we are hearing a lot about it, and it's useful to have some real facts about it. I wanted to briefly discuss this condition called the multi-system inflammatory syndrome, and not because it's very common, just because we should have an understanding of the clinical picture of this disease, this condition, and we should know how to treat it. Okay, so I've spoken a bit about this before, but many countries and around the world are starting to talk about MISC. I was on a meeting with people in Fiji recently, and they were talking about children that might have had MISC, and I think we need to at least understand what it looks like so that we can recognize it if we do see it, and know that we shouldn't be scared of it. Right? Now MISC is a syndrome that occurs somewhere between 1 and 3 weeks after COVID. It can occur even up to 3 or 4 weeks, I think, after COVID. I've seen a case a month after COVID. And I've also seen a case of MISC in a child who actually had active infection at the time. So it's really an inflammatory response to COVID. MISC was first reported in the UK and in the US and Europe about 2020, in Italy and other countries. But now there's been lots of cases reported from India and South Africa and Brazil, all countries that have had a lot of COVID. It is relatively uncommon, and that's important to know that severe cases are relatively uncommon, I think. So out of 93,500 cases of COVID in South Africa, there was only 100 cases of MISC, and so it's really quite an uncommon condition, and it's usually not life-threatening, not very life-threatening, although some children have died from it. In fact, the first 23 cases in South Africa all survived. This was written up. I don't know about the other cases, but they've documented the survival of the first 23 cases they described, and that's been my experience with the children I've seen. Almost all they've survived with really basic supportive care. We need to know the criteria for MISC, because it looks a bit like other viruses or other bacterial infections. And so the children have a fever above the WHO criteria. The fever is above 38.5 degrees for 3 to 5 days, typically like that. Sometimes even higher fever, 39 degrees or 40. The child has, the criteria are the child would have any 2 multi-system abnormalities. So they might have, usually they have a rash. Not always, but usually they have a rash. And the rash might be on the skin, also in their eyes, so they have conjunctivitis. They tend to have edema or swollen hands and feet, not always, but often do. They often have some respiratory symptoms like cough or respiratory distress, or they're hypoxemic, and they invariably have hypotension. So they're invariably, their blood pressure is low, and they have other cardiovascular signs. Sometimes they have neurological signs like headache and myalgia, confusion. They look a bit like they've got a really bad case of the flu. And as you know, they often have gastrointestinal signs like diarrhea, abdominal pain, and sometimes they present dehydrated and need some rehydration. So dehydration with hypotension, a red rash, and a high fever should make us think of MISC. Now, like as I said, this syndrome is looks a lot like other viral syndromes, like a really bad case of the flu or streptococcal toxic shock syndrome. Some staphylococcal infections give you almost identical clinical features. And so sometimes it's quite hard to distinguish between the different sorts of inflammatory disorders like this. So these are the features that are common: a high fever. The children are lethargic or tired. They often have swollen hands and feet and a red rash. They often have abdominal pain and vomiting and diarrhea. Sometimes lymphadenopathy, so enlarged lymph nodes, particularly in the neck, usually on one side. They often have red, cracked lips or a strawberry tongue, and they often have conjunctivitis. So if you see all those features, then that fulfills the WHO criteria for MISC, multi-system inflammatory syndrome in children. But don't forget, it could also be, if you see a child like that, they might not have COVID-related MISC. They might have streptococcal infection or staphylococcal infection. Yeah? These are some pictures of children that have MISC, and you can see the blotchy red rash, a little bit like urticaria, and see how swollen the fingers are. Is another child with the similar sort of rash and the conjunctivitis. So they have blotchy erythematous macular rash, and often they present with abdominal symptoms and vomiting or diarrhea and dehydration. The treatment for MISC is entirely supportive, and almost all children who give good supportive care then they usually get better, usually within a few days. And the treatment is supportive, as I said, attention to the child's airway, breathing and circulation, and particularly the breathing and circulation. They're the main ones. But the children have a relatively normal airway. They don't have stridor, apart from if they've got croup as well, but usually their airway's okay. Breathing, you give them oxygen. Often they're hypoxic, so they need oxygen. And the most important thing, I think, is to assess their circulation, because these children if they're going to deteriorate, it's usually because of a circulatory problem. And so you assess their circulation, and I want you to learn the way to do this. That's quite easy. I think we don't measure the blood pressure often enough, but we also don't make the most of the clinical signs that we can assess. And so when assessing a child's circulation, I always feel the hands and feel the feet. And there's three things you need to do. Feel the hands to feel if they're warm or cold. Look at the capillary refill to see if it's normal or prolonged. And then feel the radial pulse. And if you practice this on every child, you'll get really good at assessing a child's radial pulse to see if their pulse volume seems to be normal. And if you've got a normal pulse volume and you've got warm hands and feet and you've got a normal capillary refill, then probably their circulation is okay. And then you can measure the blood pressure and see that it's normal. I'll explain about blood pressure. So I want you to be really good at assessing this child's circulation. So just to make it clear, when you're assessing a circulation, a healthy circulation, a good cardiovascular state, the hands and feet will be warm. There will be easily palpable radial pulse. I always try to feel the foot pulses as well. So feel the dorsalis pedis or posterior tibial pulse. You should measure the blood pressure. Measure the blood pressure. I think it's really useful for us to measure blood pressure regularly, because then we'll get an idea of what a normal blood pressure feels like when you feel the radial pulse. Right? There's some other things that you can also measure, like urine output or acidosis or their mentation, their conscious state. But if you get good at feeling the hands and the feet and feeling them properly, then I think we can diagnose children who've got circulation impairment quite early. I find that there are a number of children that get missed because people haven't done this. They haven't made an assessment of the child's circulation. we're quite good at assessing respiratory signs of respiratory distress, but I don't think we teach people how to assess a child's circulation. So if you're in shock, a child will have cold hands and feet, low volume pulses, or they'll be hard to feel. They'll have a prolonged capillary refill. So that's what you do with the hands. And you measure the blood pressure. Look at the pulse pressure. I'll explain that in a minute. And often these children will have oliguria. They won't be passing much urine. And sometimes their skin will be quite mottled. I showed you a picture before. See the mottling on this child's skin. And it's not just a rash, it's also severe impairment of the circulation. Right? Okay. So I just wanted to go through blood pressure a bit, because I think it's something we don't measure very often, and sometimes we don't measure it because we don't have standards for what a normal blood pressure is for age. And I'll send this around, but these are the normal systolic blood pressure for age, so somewhere between 60 and 85 for a baby that's just born. And by the time a child's an adolescent, like over 12, then they've got a normal adult blood pressure, 110 to 124, 125. That's their systolic blood pressure. There's a range, of course. And then there's the diastolic pressure, which we need to pay attention to. And then in between that, between the systolic and the diastolic pressure, is the pulse pressure. And when you're feeling the radial pulse, that's what you're feeling. You're feeling the pulse pressure. And if you feel it's in the assessment of many conditions, particularly in sepsis or dengue, for example, we need to get very good at feeling the pulse pressure. If you get used to feeling what a normal pulse pressure feels like and measure the blood pressure as well, then I think that gives us a very good understanding of the child's circulation. So the pulse pressure normally is around about 40 millimeters of mercury. Right? So that 40 millimeters of mercury is like a blood pressure of 90 on 50. It's the difference in between 40 millimeters of mercury. That's exactly what you're feeling when you're feeling the child's pulse. Right? So an infant who's 12 months of age, we normally would have a blood pressure around about 90 on 50 or 90 on 55. And so therefore their pulse pressure will be around about 35 to 45. That's what you're feeling when you feel the radial pulse. So in children that have MISC, if they fulfill the criteria for MISC, we make a good assessment of the child's breathing and a good assessment of their circulation. And then we decide whether or not they need a bit more fluid. So if they're in shock, they should have a bit more fluid. If they're not, they don't need any more fluid, right? But usually these children, if they've got signs of shock, if they've got cold hands and feet or poor volume pulses or their blood pressure's low, then it's good to give them a bit more fluid. And I usually give 10 mils per kilo of fluid and then reassess the circulation. Right? If after a couple of drops of fluid, their blood pressure is still low, or you feel their circulation is still impaired, then you can start some adrenaline. I'll explain how to do that in a moment. All these children with multi-system inflammatory syndrome, it's good to treat them with prednisolone. So it doesn't matter whether you've got prednisolone or you've got dexamethasone. Either way, 2 milligrams per kilogram for 7 days, or dexamethasone 0.15 milligrams per kilogram 4 times a day. So there are regimes for both prednisolone and dexamethasone. They do essentially the same thing, but they're just steroid medications that is useful in children who've got MISC. I have always started these children on aspirin. So a low dose of aspirin can reduce their likelihood of getting thrombosis, and that's important. And as I said, even though you might think that this disease is MISC, then it still could be streptococcal infection or staphylococcal infection, and it still makes sense to give these children antibiotics. Because it's very difficult to distinguish between COVID-related MISC and other bacterial infections. If a child's hypotensive, despite despite getting fluid and you don't think they're very dehydrated, then using some adrenaline is very useful. And most of these children only need a very low dose of adrenaline. So this is 3 ways you can give adrenaline. All right, and I'll just explain. The first way is probably one of the best ways. I think the first way is the best way. All you do is put 1 vial of adrenaline, so 1 milligram of 1 in 1,000 in 1 litre of Hartmann solution or normal saline, and you run it at 5 mils per kilo per hour. All right, so a 10-kilo child gets 50 mils an hour, and in that way they're getting a small dose of adrenaline constantly. All right. The only problem with this is that you're giving children quite a bit of fluid, and if the child's hypotensive and needs some volume resuscitation, then that's okay too, because they're getting a bit extra fluid. But if they don't need extra fluid, they just need some adrenaline, then you need to make a more concentrated form, and that is 6 milligrams of adrenaline in 1,000 mils. And then that's the prescription. I'll send this around so you've got it. And then if giving an adrenaline infusion is not possible, it's only possible if you've got an infusion pump. But if it's not possible and the child's hypotensive, then you can give a small dose intramuscularly, and this is what we give for children with anaphylaxis, with severe allergy, allergic reaction, and that's quite effective as well. An IM intramuscular dose of adrenaline. So I tend to, if the child's very, very unwell, I give them an intramuscular dose of adrenaline, and then I try to use the first dilution of adrenaline if the child needs extra fluid as well. For MISC, there are some laboratory investigations that help to distinguish MISC from other conditions, but in reality, most of these things will be seen if the child's got streptococcal sepsis or staphylococcal sepsis anyway. So I don't think these are really distinguishing. I tend to go on clinical grounds to make a diagnosis of MISC, and if you've got access to an echocardiograph, often you see the child has myocardial dysfunction, and if you do an echo or find signs of heart failure, then those children need some adrenaline, a small dose of adrenaline. I've already said this, that it can look like other types of toxic shock syndrome, so that's why we give antibiotics. And don't forget that most children are actually not unwell. They just have fever, vomiting, or diarrhea and a rash, and they'll get better if we just provide them with good fluids and supportive care, not needing any sophisticated treatment. This is the X-ray of a child with MISC, and you can see this child's heart was a bit big and the lung fields a bit wet. So you can understand why they often need some oxygen, and sometimes they need adrenaline because the heart's not functioning very well. So this child had clinical signs of MISC and also some signs of heart failure. So this child got much better just with some adrenaline and some oxygen and some otherwise good supportive care. Comment on the situation in Fiji, because I think there's quite a bit known now about the frequency of COVID and Delta virus in Fiji. It has a very high community prevalence, and there are many children being hospitalised who are COVID-19 positive. But often the reason why they're in hospital is not because of COVID-19, but because of some other illness. And so COVID-19 in many cases is like a bystander. And that's what we're seeing also in Australia, that children that are having to come into hospital, usually with COVID-19, it's usually because they've got COVID-19 associated with some illness. And sometimes it's causing respiratory infection like bronchiolitis or pneumonia or croup, etc. And rarely they're seeing in Fiji and elsewhere rare cases of this MISC. So it's important that we know about it because it is around. This was a child that I saw this week who has COVID-19, not MISC. But can anyone see what do you think you can see on the X-ray? Well, the reason I showed the X-ray is because many people thought this child had pneumonia, a strange sort of pneumonia here in the right upper lobe. But in fact, what that is, this child didn't have pneumonia, just had viral croup related to COVID-19. And this is simply a thymus. Right? This is the child's thymus. This child was only 9 months of age. And you can see a thymus that is like this in children up to about a year of age. All right, and you can see that the X-ray is a bit rotated to the right. So this is just a normal thymus, and in fact, the X-ray doesn't show pneumonia. But often I show the X-ray because often people interpret this as being related to a pneumonia. But in this case, at least, it is just a normal thymus. So today we've talked about an update on COVID. We've talked about the Delta virus and how it's affecting children a bit more commonly. We've talked about the vaccine and how it's still effective against the Delta virus, although a bit less effective than the first COVID virus, but still effective against it. And we've talked a bit about this condition called MISC, so that you have an understanding, the clinical picture of MISC if we do see a case. So that's all I wanted to say today. I'm happy to answer any questions that you might have about all of that.